So, welcome to this version of your Pharma Talk sessions. And this session's entitled Voices from the Trenches, Real Strategies for Independent Pharmacy Leaders. And want to let you know it's sponsored by IPC, so our partners at IPC. So I'm just going to introduce these two gentlemen and get the heck out of the way and let them talk to you about what's going on in our crazy pharmacy world. But first of all, who the heck am I? My name is Mark Crouch. I'm one of the vice presidents of pharmacy retail operations with HealthMart. So think of me as a business consultant for all the tools, resources, and solutions that HealthMart has to offer. So we're going to let these two gentlemen and really industry experts riff a little bit back and forth for about 15 minutes. And then we're going to open it up for about 5 minutes of a question and answer. So without further ado, I'll turn it over to Nick. Take us away.
Thanks, Mark. Appreciate it. Hey, everybody. Thanks for coming. When they gave me the task of coming up with this, and they gave me the title, and I think about the trenches and how we fight in pharmacy every day, or how you all fight in pharmacy every day, it's like I got to call Randy. There's nobody that fights harder in the trenches than this guy, and I've known him for a long time, and I thought his background, his story, and the things that he's doing at his practice would be super valuable to tell. So appreciate you being here, Randy.
Thanks, Nick. I appreciate it.
I think there's a disclaimer. We're good. We've all seen it. First thing I think would be important is for Randy to kind of talk through his background. It's a little bit different than most people, but it's really led to all the things he's been able to accomplish. So if you want to give, they don't know you.
Sure. So my name is Randy McDonough, and I live in Iowa City, Iowa. I've been an owner, will be 20 years actually in 2026. But before that time, I was a faculty member at the University of Iowa College of Pharmacy, and I thought I was going to just have a nice, good career doing that. I really enjoyed it. Great benefits, great pay, a lot of flexibility in the job. But my purpose of being at the University of Iowa was to help community pharmacies transform their practices. I was one of the founding members of a group called the Iowa Center for Pharmaceutical Care, which is a collaborative effort between the Iowa Pharmacy Association, Drake College of Pharmacy, and the University of Iowa College of Pharmacy. And so what we did is go around the state to help to help transform pharmacies so they were moving from a product distribution focus to a patient care focus. So this is way back in the early mid-1990s that we did that. So that was going very well. But then I was challenged by one of the people that I was helping to transform their practice, and they said, well, do you have a practice? I'm like, well, no. He goes, have you ever done this before? I'm like, no. So he goes, well, until you actually show me that you know what you're doing, I'm not going to listen to you. And I'm like, that's probably fair. And so at about the same time, again, I'm still faculty at the University of Iowa, I had one of the places I was consulting with, it's Main at Locust Pharmacy, Lisa Plain, who was the owner at the time, challenged me. She said, okay, I believe in the concept, but you come here and make it work. I'll be honest, that was a difficult decision initially because I'm like, I really don't know how to do this either, but people believed that I did know what I was doing. And so I actually started 1 day a week, and that was in 1998. That 1 day a week led to 2 days a week within 6 months because we were becoming very successful in implementing some of these services. Eventually, it went to 4 days a week within a year. And my job was to help create these services. And we were very successful. We were having businesses pay for these services. We were doing health screenings across large groups of companies, big companies, and getting paid for it. I had developed a program so that we could provide services for our Medicaid population. We had a program that was called Pharmaceutical Case Management, of which we were paid to actually manage high-risk patients, and we were one of the pharmacies that was very successful doing that. So I thought everything was going well. I was moving forward with my career. It became my laboratory. I started doing research. I was publishing all this stuff. And then lo and behold, in 2005, I went to an APHA meeting, did a presentation about how community pharmacists can step it up and do this. And then someone challenged me again. And this time they said, but do you own a practice? I'm like, well, no, I don't own a practice. I play with someone else's money. And they said, well, until you become responsible for payroll, you don't know how hard this is financially to make these decisions. That was in 2005. At the end of 2005, it was just, fate has a way to bring it up to you, but one of my former mentors came to me and said, hey, I want you to do it main at Locust, but I want you to do it for us here at Towncrest in Iowa City. And I thought initially he meant I'd stay at the university and do this. But he said, no, I want you to leave the university. I want you to become an owner of Towncrest Pharmacy, one of the co-owners of Towncrest Pharmacy. And your main job is to create what you create at Main at Locust Pharmacy. So you may have heard on the big stage, on July 1st, I became full professor. And I knew I was going to make full professor. And then on July 5th, I left. And so over the 4th of July weekend, they put on my door, Randy McDonough, full professor, and I only saw it for one day, and then they took it down. So that started my adventure of being an owner, co-owner with Michael Denninger and now Kelly Kent and Aaron McDonough, my son. And so for the last 20 years, it was my own money now. And I do put my money where my mouth is. And so I've invested in a lot of different business strategies, new business models, to bring in new kind of revenue outside of the dispensing model, and that's been my thing for the past 20 years, and I've been very happy that I can look back and saying, you know what, it worked, because that was the big thing. Why did I leave my nice, secure university job? Because I wanted to prove to people, proof of concept, that if you believe in the concept and you believe in what you're doing, it can work, and so that's what happened, and I left, and 20 years later, here's where I'm at.
That's right, that's right. My favorite things about Randy, and he kind of alluded to it, is the guy loves challenges. He may not say it sometimes, but he always finds a challenge, and he loves to lean into it. Can you talk about some of the recent challenges you guys have really been facing? I can think of a few, but like payroll, and I know everybody is worried about pharmacy, where it's going. What does Randy do? He buys more pharmacies. I mean, what kind of challenges have you guys been able to solve?
Well, during COVID, we were very successful as a practice. We were already doing all kinds of immunizations. We were doing a lot of patient care services, so test and treat, point of care. That was nothing, and then really doing some very large volume vaccine programs for the communities was wonderful. What I realized during that time is that I wasn't a solution just for those patients who came to my pharmacy, but I started recognizing we were a solution for the community. So people we never worked with before, public health departments, social services, senior citizen centers. I mean, we started finding these opportunities of working with them. And so I started thinking, you know what, we have a good brand. And so I realized we had some money that now we had put in the bank because we had done COVID and done well. I heard everybody say we're the woes of community pharmacy, where it was going to go. So I said we could do two things with this money. I can sit on it and just saying, let's just hope for the best, and that's what I think a lot of people did, or we can invest in it. So Nick calls me up. This is a true story. Nick calls me up. I can't remember where I was at, but I was flying. And I'm at the airport. Nick calls me up. He goes, Randy, I've got this great pharmacy that I think you guys would be interested in buying. I purchased it before I boarded the plane. It was that fast.
It was pretty quick.
I mean, I was asked for the financials. I called my partners. And before I was getting on the jet bridge.
Yeah.
And I had talked to the previous owner, and we had agreed to the price. And I said, okay, this is how it works and stuff like that. But we decided to invest and go into more rural areas. And so we bought 4 pharmacies. But I also, during that time, my son had just graduated. He was a COVID graduate. And I brought him on as a full partner, 25%, and said, your job is to create this new cash-based practice. I told him initially that he couldn't become an owner with me until he did a residency. But I started seeing during his rotations how innovative he was and entrepreneurial. I'm like, I might lose him, actually, if I have him go somewhere else. Someone's going to see that entrepreneurial attitude. And so we brought him on, and then he opened up TWA, which is Towncrest Wellness Apothecary, total cash base, no insurance. It's functional medicine, non-sterile compounding, cost plus, and that's our bank now. That one's bringing in margins about 60 to 70%. We're licensed in 6 states now, including the Virgin Islands. We also sell our functional medicine not just nationally. He's very good with social reels and online marketing, and so we also sell internationally. So that has really done a good job for us. But then we also got involved in something called pharmacy care at home, which is a medical care at home model. We have a closed door pharmacy that's attached to our cash-based practice. The closed door, but we don't take care of any facilities. And everybody goes, well, why'd you go down this road? I said, well, it made sense because of some of the contracts we could get to be a closed door. But our forte has always been that ambulatory patient you're trying to keep home. We are already doing group homes, which we're doing something very similar. So we just branched out to that. So we got about 700 patients that we take care of on a regular basis. Better reimbursement on the product side, and we've got the group homes paying us to manage the patients on the service side. So that's been a really good model for us as well. But otherwise, our main pharmacy, Towncrest in Iowa City, is our hub of clinical services. And that one's done a very good job of demonstrating what is possible within community pharmacy and clinical services.
Awesome, awesome. The moral of the story is challenges breed opportunity. And as many challenges as there are today, there's that much opportunity. You just have to know where to find it. And with that, what are some opportunities that you think that people aren't thinking about that may be in their markets that they should be exploring?
Well, if you heard me on the big stage and heard my panel discussion, my biggest concern right now is I don't think pharmacy as a whole has stepped it up to the level that I think they should be stepping it up to. When I talk about inappropriate medication use, and how many people were at my panel discussion earlier today, where I talked about the cost of inappropriate medication use in this country. It's high, right? I said for every dollar we spend, and this is 2016, for every dollar we spend on drug therapy, we spend another $1.55 to correct the problems associated with it. Back in the 1990s, it was Johnson & Bootman study that said for dollar, for $1 we spent another dollar to correct it. So now it's $1.55. A drug spent in 2022 was $405 billion, and I started looking at just some of the stats that are out there. I think we're spending $2 now for every dollar we spend on drug therapy to correct the problems associated with it. So my thing is this. We still have a pandemic going on in this country, and that pandemic is inappropriate medication use. Pharmacists, and in particular community pharmacists, can be the group that can rise to the occasion, right, take full advantage of that, and we're seeing more payers seeing that recognition, yep, but they have to see that it's happening. When I go speak with payers and I go speak with other stakeholders, they're like, okay, you can do it, because we know you've proved it and you've demonstrated with your documentation and data, but can all pharmacies do that? Right. I know they can. In Iowa, we have CPS in Iowa, which has been very successful, and we were part of a bigger program, value-based pharmacy program, of which we saved the payer almost $15 million in 1 year. And that's
one pharmacy, right?
Huh?
That's one pharmacy.
No, with my pharmacy, it was 2.4 million.
Wow.
But overall, with all 74, we had 15 million. And so they actually gave us an enhanced dispensing fee just for our network because they believed the value in what we were doing. Yeah. Now we're looking at medical billing, so billing on the medical side. And so that's becoming a huge emphasis for us right now. So we're investing resources in that and actually becoming very successful and being able to bill appropriately for that too. So
that's awesome. I think it's time for questions. Anybody got any questions out there for Randy? Time to ask the expert? Yeah.
Pretty much across the board, when I talk to successful pharmacists, they don't open up a traditional store anymore. They open up compounding pharmacy, infusions, and long-term care facilities.
And why?
Because margins. They're the
margins
only...
on the product side are better.
That's correct.
Right? Yeah.
Right. Is traditional pharmacy dead at this point?
No. That's a really good question, but I don't know what your definition of traditional pharmacy is, but traditional pharmacy of being a dispenser is dead. That's dead. I believe that when I started my position at Towncrest. I said, because when I started, I can remember one of my partners coming to me and saying, hey, remember, this is a cash cow. That was a dispensing model. I said, today it's a cash cow, tomorrow it will be a dead cow. And I was right. And so what I think it is now is that we have to be service providers and we have to get paid for those services. That's why I say medical billing and really being recognized as a provider. I'm frustrated that it has to be compounding or long-term care. It's not because people want to provide services. Human beings want the low-hanging fruit. So they're going to go where it's, okay, I'll just open up this type of pharmacy where I get better margins, right? Not that you don't have to work hard at it, but I want to talk about us as drug therapy experts, and that is not being said enough. And I think that, to me, is the future along with some of these specialized practices. But we got to step it up. We got to demonstrate, because so when we did this program with the payer and we saved them $2.4 million, that was their data. Then I went and looked at my data, and we're documenters, we do clinical services, we keep track of all that. I could show them, and that was also published, we made 17,000 clinical interventions. And I could show them the type of patients we made it on, the people who had chronic conditions, the patients who had high-risk medications, patients with polypharmacy and chronic conditions. I could pinpoint to everybody. And I'm thinking, every pharmacy should be able to do that. I mean, didn't we all go to school to be the drug therapy expert? I think we did, right? That's why I went to pharmacy school. But yeah, we've got to do some of these other things to help with our margins. But ultimately, what I want to do is be that drug therapy expert for my patient as their advocate, because I am the last level of defense for that patient. And if I don't take care of that, it's not getting done. And that's why we have, just so you know, that inappropriate medication use, that includes 30,000 deaths in 1 year, and that was 2016. I can tell you it's probably more than that now. If we're not stepping it up, I do think we're going to be replaced. And I'm very concerned about AI, because AI, gets smarter and smarter as it gets the problem solved. But I don't think you can replace the humanness, because humans are complicated creatures. AI can take care of some things. It can complement what we do, but ultimately it's going to be your decision and your understanding of the complex nature of that individual patient that's going to help them achieve their therapeutic outcomes. I hope to God, because I'm towards the end, my vision, I hope, is that everybody steps it up and we're starting to demonstrate to payers, like, wait a minute, how come we haven't been paying pharmacists to provide these services? Because this is helping us reduce overall healthcare costs. That's where I hope we get to. So I don't think the model of pharmacy, the way I saw practice, is dead. What's dead is if you're just dispensing, there's no services involved in that, you're not helping patients achieve their therapeutic outcome, that's been dead for decades.
Good question. Any other questions?
Hi, Vicki.
Hi, Randy. Thank you. What advice would you give to the owners and pharmacy teams here to enter into a relationship with a payer or a local employer? Like, what's the first step for
persistence?
For that?
Okay. I think it's a really good question. Persistence is one. So let's talk about my relationship with the biggest payer in the state, how that happened, and it's even changed since that time. They hated me initially because I was sending information into the insurance commissioner's office about how my reimbursement's crap and how this is wrong and everything else. And so they did not ever want to meet with me. And so that was an issue, and I knew that. But what happened is when we saw the floor drop from under us and reimbursement had gone down so much because of the new PBM that they had, I decided to reach out from a human perspective. And so I wrote about a patient case, and it was a young man who's in his early 20s. He was on an old-time medication, clomipramine. The month previous of me filling this medication for the young man, it cost me $30 to get him, a 30-day supply. Overnight, from June to July, it went up by 8,000%. So when I dispensed it the next month for this gentleman, it cost me over $700, and they still paid me as if it cost me $30. So I was losing $700 every time I filled it for this person. I went through all the proper procedures with the PBM. I documented everybody I talked to, and nothing, no relief, no change. And so I finally decided I'm going to write to the CEO of the health plan, which is against the law, right, or against the rules, against the contracts. But I decided I was going to put a note together and send it to the CEO. Well, first of all, how many people here think it's easy to find contact information for a CEO of a health plan? It doesn't exist. So people go, how'd you get it? I said, I did a Google search all day long, and on about the 500th, this is a true story, about the 500th page, I saw this email that I'm like, this could be it. So I took a chance. And so I sent it to the CEO of the plan and said, I want, you say behind every claim is a human being. That's their tagline. I said, let me tell you about a human being I'm taking care of. And I talked about this young man who has OCD and been in and out of the hospital. I said, ethically, I cannot fill this medication for this young man because it's kept him out of the hospital. But ethically, I think you have a responsibility to me, because being the owner or co-owner of Towncrest Pharmacy and the CEO, the buck stops with me. I have to think you being the CEO of this corporation, the buck stops with you. I sat on that email for a few hours, and I remember saying, if I send this, I may lose my contract with the PBM, and that represented about 40% of my patients, and I was a little bit nervous as I was doing this. But I asked my business partner, Mike, at the time. I said, Mike, do you feel comfortable if I do this? And Oh, there's Mike. And so Mike was supportive, and my resident, who didn't have any stake at all, says, "Oh, send it." I'm like, "Yeah, you're not gonna lose anything." So this is a true story. I sent it. As Mike knows, I went home, and I think I had a 12-pack. And I'm like, let's see what happens. Well, the next day, the shit did hit the fan. I'm sorry if I can't say that, but literally, and Mike knows the story because the phone started going off the hook, and Health Mart Atlas was saying, "What did you do?" And I said, well, I sent a letter to the health plan, and they said, "You can't do that." I'm like, "Yeah, I know that." And I said, "You don't tell me what I don't know." And so the PBM was calling and saying they're very upset that I did that, but the health plan did call me. The CEO sent me an email back. Then the chief pharmacy officer, who didn't like me initially, said, "I'd like to have myself and also our chief operations officer come out and visit your pharmacy." Mike was there. We took him on a tour of Towncrest. That was a few days later. And that's when I said we were talking human to human at that point. It wasn't me as a pharmacy, you as a health plan. It was two human beings. And I got very emotional because the night before they came, and you all know, being community pharmacists and owners, you have a difficult life, right? You have time management issues. I got to one soccer game for my daughter, and I had to leave because we had a hospice patient who was dying, and I had to get morphine to them. So I saw not even the first half of my daughter's game, and that was the only soccer game. So I got very emotional when I talked to the chief pharmacy officer and the chief operations officer, and it got tearful. And I said, "I do this because it's the right thing to do for the patient, but I want you to know I lost money filling that medication. What value do you place on me doing this for you?" So they left, and we had exchanged phone numbers, cell phones. Literally 10 minutes outside of them leaving the pharmacy, I get a call from the chief pharmacy officer, and this is where I realized we connected on an emotional level. And he said, "Randy, I want you to do me a favor." I go, "What's that?" He said, "I want you to go home tonight, and I want you to get a good night's sleep." He goes, "We're going to figure this thing out." And then we started the pilot within months of starting the pilot, and that's when we demonstrated to them that our pharmacy was able to save them $2.4 million. And so from that day on, we've had a nice financial relationship with them.
That's right. That's right. Awesome. I think that's it for questions for now. If you guys have anything else, we'll be off stage, but really appreciate this,
Yeah,
Randy.
thanks, Nick. I appreciate it.
Thanks, guys.